Thank you. Welcome everyone to the third session of our symposium. We will be reviewing COVID-19 therapies and vaccines in the pediatric setting. My name is Gina Montealegre. I am a pediatric rheumatologist and physician scientist at the National Institute of Allergy and Infectious Diseases. It is my great pleasure to introduce our three speakers for this session. Our first speaker is Dr. Andrew Pavia. Is a George and Esther Gross Presidential Professor and Chief of the Division of Pediatric Infectious Diseases and Adjuncted Professor of the Medicine at the University of Utah. He currently serves as an advisor to the CDC and the Utah Department of Health on COVID-19 and is a member of the NIH COVID-19 Treatment Guidelines Panel. With this, he will be talking to us about the therapeutics for children with COVID-19, trying to be data-driven in the absence of pediatric trials. Welcome, Dr. Pavia.
Well, thank you very much. It's a pleasure to be here. And I just want to say that after the beautiful basic science that we heard and the detailed dissections of what we're beginning to understand about the immunopathology in children, this is going to be a disappointing talk, because if we are going to confine ourselves to high quality data about the treatment of children with COVID-19, we could move right on to the next talk. There's a complete dearth of high quality data. So we're going to make do with what we have. These are my disclosures. So what I'm going to do is to review the epidemiology of COVID-19 in children. What I want to emphasize is that not all children are the same. Children are not the same as adults. They're not little adults, but neither is a 2-year-old the same as a 15-year-old or an 18-year-old. We're going to look at available data on the predictors of severe disease. Clearly, we don't have the kind of biomarkers that you just heard about yet, but how do we use those clinically? Then look at the current therapeutic options that we have and the strength of the data for adults, and try and apply this in a practical way to children. And really the last thing I'm going to do, which is probably the only thing that will really be useful, is to look at the critical needs that we've not yet met. So if we think about the epidemiology of COVID in children, they still represent 12 to 14% of children in the US. Most of the cases nowadays are in children over the age of 10 years. And so that's about 70%. Underrepresented populations are overrepresented in cases. They also have worse outcomes, are more likely to be hospitalized, and in some studies are more likely to end up in the ICU. Overall, looking across a variety of series in the US, about 2.5% to 4% of lab-confirmed cases among children end up being hospitalized. So these are the people that we want to think about when we think about therapeutics. But once hospitalized, children don't do a lot better than adults. A number of series have suggested that up to a third end up hospitalized. This is not distributed equally among children. And I'm sharing below a graph from an early study, actually from Dr. DiBiase, there in DC, but the data, sorry, my slides seem to be advancing on their own, but that shows that the age distribution of hospitalization shown in red follows a U-shaped distribution, but the age distribution of severe disease, then as ICU admission, is largely skewed to the right, with older children ending up in the hospital. And the older you are in adolescence, the more likely you are to end up with severe disease. It's probably telling us something about the biology that we haven't yet dissected. But the numbers that I just showed you may not be very accurate. Hospitalization may be overestimated because of routine testing of children on admission, and cases may be underestimated because younger children are less likely to be tested. And I'm just showing you some data from a population-based seroprevalence study that we did in Utah, showing that seroprevalence by age didn't vary a whole lot, between 15% in the under 12s up to a high of about 21%. But the proportion of those who were seropositive, who had a previous clinical diagnosis, was very different. Only a quarter of the younger children had been tested and diagnosed, compared to 60% in the older adults. So our denominator for younger children is clearly skewed. So I'm on the clinical service. I have to think like a clinician this week. So I wanted to put this talk in the context of a child we consulted on just 2 days ago, and think about what we know about treatment for someone who's complicated, like this 11-year-old who has significant obesity with BMI of 36, very insulin-dependent diabetes. He also has obstructive sleep apnea and a nighttime oxygen need at baseline. He was admitted for glucose control about 10 days ago. And on routine admission testing, he was COVID positive, but he was really minimally symptomatic. And he was discharged with no treatment and was doing well at home until about 7 days into his illness, when he developed an increasing oxygen demand. He had a fever, he had increased work of breathing, and he was admitted. Initially, he required oxygen, but only a fairly modest amount, and was doing fairly well. But he followed a fairly adult-like course in that over the next 3 days, he had rapidly increasing oxygen needs. It was up to 10 liters. I had an ID consult and an evaluation by the PICU team to consider whether he was transferred. So if we think about each stage at which he presented, what are our treatment options? And what do we know based on the adult data? After the beautiful immunobiology you just saw, this cartoon, which all clinicians know by heart, is pretty simplistic. But when we think about therapy, we postulated that early on, what we want to do is augment the antiviral effects using either small molecule antivirals or antibodies. And later in the disease, we need to deal with the immunopathogenesis and treat with immunomodulators. Clinical trials have proved that this model is pretty robust and seems to work pretty well. And the clinical staging that's been used for the ordinal scale to evaluate clinical trials has turned out to be pretty effective in designing treatment strategies. What I'm showing here is familiar to all the clinicians. It is from the NIH treatment guidelines and uses as clinical stages the same stages that are used in the ordinal scale, and makes evidence-based recommendations for treatment at each stage of disease. None of these are validated in children. No children were included in trials for any of the data that underlies this. So let's go through it a little bit systematically and think about the problems that we face. So there are only 5 of us on the NIH guidelines panel who are pediatricians, and we've struggled with how to frame the questions that we face for children. And these are the key points that we wanted to emphasize. Most children, particularly outpatients, will never require specific therapy. Those with mild or moderate disease generally only need a supportive care. We really have a complete absence of placebo-controlled randomized trials and relatively limited quality and quantity of data from observational studies to inform specific treatment. So in the absence of that, what do? We do what pediatricians always do. We evaluate the adult data very carefully, try and think about how it can be extrapolated to children, try and extrapolate the pharmacokinetics and safety data. And in the case of treatment of COVID-19, we try and base the decisions based on the risk of severe outcomes, as well as what we know about the efficacy and safety. But what do we really know about the severe outcomes? We have decent but not exceptional data on risk factors for adults that predict progression. And these are just what we're looking at right now are underlying conditions and clinical risk factors. But for children, the data are pretty sparse. The best data we have comes from the CDC's COVID-Net, and this is several thousand children now. This is looking at the prevalence of underlying conditions among those who are hospitalized. And what you see is that 45% have no underlying condition. But among the rest, underlying medical conditions are quite common. They're often present multiply, and obesity, neurologic disease, and asthma are the most prevalent. And this holds true for studies from other countries as well, although obesity, sadly, is more prevalent in the United States. Apologize for the slide advancement issues. What we'd like to have are really good epidemiologic studies that give us a quantitative estimate of risk. These are in very short supply. We mostly have very small series. The largest series I could find is a French series that involves only about 310 children. And what they found was that the odds ratio for progression to mechanical ventilation, invasive or non-invasive, or ECMO, was highest for children over 10. This is similar to other studies that have used higher cutoffs, and seems to be a linear increase in risk as you age, and the presence of any comorbidity. If you drill down to the specific comorbidities, then chronic respiratory disease other than asthma, immunosuppression, and neurologic disease were statistically significant in this relatively small series. Some others have suggested that diabetes and obesity are independent. But this is pretty limited data on which to make those clinical decisions. So when we think about the children who are not yet admitted and try and apply the tool that we have for that population, which are monoclonal antibodies, we're really struggling a bit. In the adult studies, which were done with the 3 available monoclonal antibody products, the patients who were enrolled were at least moderately elevated risk of progression. The clinical endpoint was progression to hospitalization or death. There were few deaths. And there was a relatively modest but clinically important absolute risk reduction of 3.5 to 6%. But these are in adults starting with a higher baseline than most of the children we see. Although the EUA allows treatment of children under the age of 12, very few were enrolled in any of the 3 products studies that are out, either published or in preprint at this point. So what can we say about that? Well, we really need to stratify by risk as best we can. The guidelines put it this way based on adult studies, and I won't bore you with reading the product names, but the 2 licensed and now, authorized, and now the 3rd, SeroPrevalence, can be considered for non-hospitalized children who meet the EUA criteria, which are very broad, especially if they meet more than one criterion, or if they are older than 16 or on a case-by-case basis. At present, our antiviral armamentarium is limited to remdesivir. It's the only drug which has proven clinical benefit. That clinical benefit was demonstrated in the NIH Act 1 study, and it was predominantly a 50% improvement in the relative time to clinical improvement, and that translated to about a 5-day overall improvement. There was no overall mortality benefit, and most of the benefit, when you did a subset analysis, was really seen in those who were on oxygen but not mechanical ventilation, the ordinal scale 5 category. And in that group, there was actually a suggestion, if you accept that it's a subgroup analysis, of a mortality benefit. The large, simple adaptive trial Solidarity did not show an overall mortality benefit, but was really only designed to look at mortality and really couldn't look at other outcomes. There is, again, if you look at the sort of a quasi-meta-analysis done by the authors in Solidarity, you see that, again, in the bottom panel, in the low-flow oxygen group in Act 1, there was a mortality benefit. There was a suggestion of a mortality benefit in the combined low-flow and high-flow oxygen group in Solidarity. So this is solid evidence of a modest benefit, I would say. Though when it comes to children, there are no trial data. It is licensed for children up to age 12. It's available by EUA for younger children. It's now been used in thousands of children, but from the compassionate use study, we now have published safety data that shows that it's really quite safe in children, which provides us, evidence of a benefit in adults and little evidence of harm. So the guidelines recommend the use of remdesivir for hospitalized children greater than 12 years of age who have risk factors for severe disease and emergent or increasing need for supplemental oxygen. And then those older than 16 to essentially follow the adult guidelines and to give it to those regardless of their risk factors. And it's then there's language making it flexible and allowable for children under the age of 12. Again, I hope you appreciate how unsatisfying this is from the point of view of a clinical trialist or an evidence-based medicine person. But clinically, we've all had to treat hundreds of children based on this rather scant evidence. Dexamethasone is perhaps the drug with the largest clinical impact so far, based largely on the recovery study. Just to remind you, it's a very large, open-label, unblinded, simple trial that evaluated dexamethasone versus usual care, over 6,000 patients. The mortality benefit overall was modest, but 3% is clearly important. But the effect was quite large in the sickest patients on mechanical ventilation or ECMO. There was a modest benefit in those on non-invasive mechanical ventilation or non-invasive oxygen. And there was a trend towards harm in those who were not on oxygen at all. So based on that, it's a strong recommendation in WHO, NIH, and CDC, and IDSA guidelines for all adults who are on ordinal scale 6 or 7. But for children, we have to make the assumptions based on our long experience with the drug and extrapolating. This may be a little bit dangerous because the differences in the immune response in children, it may make a lot of sense in older adolescents and may be a riskier assumption in the youngest children. Nonetheless, the guidelines panel recommends the use in those who are requiring high flow oxygen or worse. The area that's changing really rapidly in therapy for adults is the use of more targeted immunomodulators, the IL-6 inhibitors, the JAK inhibitors, and IL-1 inhibitors. Early studies of tocilizumab and other IL-6 inhibitors either had mixed results or showed no benefit, but 2 recent large studies that were done in an era where everyone was receiving dexamethasone with or without remdesivir, and that were focused on very specific subgroups, showed a clinically significant mortality benefit that includes remap, cap, and recovery. And based on this, using those trial criteria, it is now recommended for patients who are recently hospitalized with rapidly increasing oxygen needs, and for those who are within 24 hours of admission to the ICU. Similarly, based on the as yet unpublished, blanking on the name of the study, but study that's just out in preprint with baricitinib, it is recommended for patients who are on high flow oxygen or non-invasive mechanical ventilation based on high markers of inflammation, because this was the entry criteria for this study. But when we look to children, there are no data. Baricitinib is not licensed in children. Tocilizumab is used rather sparingly for a few indications, and anakinra is used widely, including for MIS-C. So there really are insufficient data to recommend for or against. And there are a large number of drugs that have fallen into the category of do not use. And perhaps most importantly, that includes convalescent plasma. So in the last couple minutes, I really want to talk about where I'd like to see the field go for children. We could make decisions much better if we had accurate clinical predictors of progression. If we could do that epidemiologically with good understanding of the contribution of individual risk factors and combined risk factors. Ideally, we really should have sophisticated biomarkers of progression. And the work you saw earlier today really raises the possibility that that can move beyond simple things like ferritin levels and CRP. Any pediatrician who's talking about the treatment of infectious diseases starts with a plea for better clinical trials. And I would like to see that happen as we move into the new era of the novel candidates for antiviral therapy, particularly molnupiravir and some of the drugs that are just entering phase 1 trials. In spite of the plea, I don't think that's going to happen in the US, Canada, or the UK, because it's just going to be hard, we hope, to enroll enough children, and logistically hard to do it in countries that are currently experiencing big outbreaks. We really need specific data on immune modulators. Hopefully that can be guided by deeper understanding of the immunopathogenesis, but I think the use of immune modulators in children without clinical studies is problematic. All treatments, whether it's with monoclonal antibodies, antivirals, or immune modulators, ideally would alter the long-term sequelae, which are becoming a big problem for children now, and we need to study that. Monoclonal antibodies have been used for early treatment, but really the great promise, I think, is in prophylaxis in high-risk populations. There are studies not yet published on the use in families and in nursing homes. I'd like to see that done in similar populations of oncology patients, those with primary immunodeficiencies and children too young to be vaccinated. And lastly, children with primary immunodeficiencies and B-cell leukemias and lymphomas represent an important subgroup for which we really need better treatment and better prophylaxis. So I'm going to stop there and thank the members of the NIH Clinical Guidelines Panel who helped us think through these very difficult problems, including the people listed on that slide. And I'm going to stop there and turn it back over.